My presentation will deal with the CEUS. So in this less than half an hour, I will try to introduce you, particularly for those people coming from countries where CEUS is not available, to introduce you CEUS and to discuss the possibilities and limitation of this imaging, not so new, but this rather new imaging modality. And we will try to discuss the role of CEUS in comparison with the other imaging modalities for the liver, and then we will go deep into the focus of this discussion, that is characterization of focal liver lesions. And finally we will try to discuss some conclusion. So what is contrast-enhanced ultrasound? It's a less than 5 minutes exam which is carried out as an ultrasound grayscale study, but with a low mechanical index, with a dedicated scanner and probes, after injection of a really little volume of a contrast medium. And of course it's a real-time imaging modality, the only one, so there is a high temporal resolution allowing to detect very details, very fast changes into the lesion. CEUS assessment is based on the evaluation of the behavior of the lesions in comparison with the surrounding parenchyma, so the lesion can be hypoized or hyperperfused during the various phases of contrast circulation. And so the different kind of focal liver lesion, we must know their behavior through the various phases. And then we will also try to recognize the morphological patterns of enhancement, homogeneous, inhomogeneous, rim-like, globular or spoke-wheel. And so we will match these changes, morphological and perfusional, over time, and we will try to characterize the different focal liver lesions. What about the possibilities and limitations of CEUS in the clinical practice? We must start, of course, from baseline ultrasound. Surely most of the focal liver lesions, with the only exception of very typical hemangiomas, are indeterminate at baseline ultrasound, and the various Doppler techniques do not add much to these possibilities of characterization. Instead, CEUS is very accurate in characterizing these lesions. Its accuracy does not depend on the size of the lesion and on the baseline appearance of the lesion, the degree of echogenicity, or on the kind of the background, whether normal or fatty. So we have now a number of studies, prospective multi-center studies with a large number of patients and lesions, which tell us that CEUS is more effective than baseline ultrasound in characterizing these lesions, and almost as effective as the reference standard. The presence and the speed of the washout of the lesion, of the loss of the enhancement, is particularly a key point, because it allows us with a good confidence to differentiate benign from malignant lesions. As a matter of fact, a hypoperfused lesion in the portal sinusoidal phase is very suspected until proven the contrary for malignancy. Of course, we have some exception. We thought this was metastasis in a patient with a breast cancer, but we submitted this patient to biopsy, and in the end it was a focal granuloma, eosinophilic granuloma. But this surely is the exception, and the rule still is correct. The value of CEUS has been considered also in patients with diffuse liver disease, different kinds of abnormal parenchymal background, and you see how, while passing from US to CEUS, how the confidence of the operator improves, and also their concordance between their agreement between the two readers. Also in this other paper with a lesion on bright liver background, hypoechoic lesions, there was an improvement in the accuracy in the area under the curve and in the K between the two reviewers. This is just an example of an undetermined lesion on fatty liver background, which turned out to be an hemangioma. So, what about the comparison between CEUS and the other more established imaging modalities of the liver? We have to stress how CEUS is less invasive from the X-rays and from the pharmacological point of view. It doesn't need fasting for the patient or any laboratory preliminary testing. So, of course, it can be performed immediately, particularly when we find, but not limiting to, the case when we find an undetermined focal liver lesion at ultrasound. We can, I work in a cancer institute, so our experience is to frequently perform CEUS immediately after an unclear CT or MRI or PET study, frequently using the same venous access of the previous study. And the contrast volume can be repeated or fractioned in different ways. So frequently we assess undetermined findings of other imaging modalities in this patient with a suspicious uptake in the segment liver 4. The oncologists called for CEUS because the oncologists in our institution have understood this possibility of CEUS, and this turned out to be not a liver lesion, but a second cancer in the gallbladder. So, in a 1 year period, we considered the kind of CEUS of the liver performed in our institution, and most of them, of course, were performed because of unclear baseline ultrasound findings, but our, let's say, surprise was to see that a number of exams turning out to be 22% were performed because of undetermined findings of other imaging modalities, CT, PET or MRI, or frequently because of the discrepancy between two different imaging modalities. This is just a case, positive CT, negative PET, CEUS shows small metastasis. This is not because CEUS is better than the other imaging modalities, of course, but just because it's a very simple technique which can be performed immediately. So we tested CEUS in various practical scenarios. For example, the frequent case of very small focal liver lesions not determined in their final diagnosis at CT. We carried out with this simple study performing a focused ultrasound. If ultrasound found a cyst, we stopped the algorithm, of course. Otherwise, we underwent to CEUS, and in many cases we were able to achieve final diagnosis. So from this point of view, CEUS is a simple and now a standardized modality, which is becoming a problem-solving tool. We really frequently employ it as a second look modality in case of doubts or discrepancies between other imaging modalities in our Cancer Institute. Also from the point of view of economy, the impact of CEUS has been tested in many countries until now. In this Italian study, the classical algorithm going to CT or MRI in the case of inconclusive diagnosis was less cost effective than the algorithm based on the second level CEUS and on going to other imaging modalities only in cases still being undetermined at CEUS. And this other Italian study highlighted how the cost of the single examination is lower than CT, and so in this period they could save a consistent amount of euros. And also in France they could see the lower cost of CEUS in comparison with CT and MRI, and this is the number of euros in the end they could spare using CEUS instead of the other imaging modalities. Of course, CEUS has a number of limitations. A liver and a patient which is difficult to be evaluated at baseline ultrasound will still be difficult after contrast injection. So CEUS will not save a difficult ultrasound scan as a general rule. Different software from different manufacturers may perform differently. Different contrast media, when they will be available, may behave differently. Some changes, since ultrasound contrast media are blood pool agents, some findings are not recognizable with CEUS. Let's just say in CT we can characterize a cholangiocellular carcinoma because of the late phase enhancement. This is a finding due to the spread of the contrast medium in the interstitium. The ultrasound contrast medium does not spread, so we cannot see this change. The very deep lesion can be hard to be, more difficult to be characterized. And we have the problem of the arterial phase, which is very fast. So multiple hypervascularized focal lesions in different segments of the liver are difficult to be evaluated at the same time. We need to use multiple injections if needed. So let's go into the problem of characterizing the focal liver lesion. This is of course really a daily issue, and even today we can have problem in this assessment. You see these very recent studies where a number of lesions believed malignant otherwise turned out to be benign after resection, or in this other series from the USA, from the MD Anderson Center, the 10% of the lesions which were thought to be metastases at CT in the end turned out to have a different final diagnosis of biopsy. So even today there is a problem of a non-invasive characterization of focal liver lesion. Which are the needs? The first need, of course, is to differentiate benign from malignant. In the end, we will try to have a definitive histological diagnosis, but I wrote here at any price, because probably for small lesions we don't need really to have a final diagnosis of FNH, adenoma or angioma. For very small lesions there is not, in my opinion, really the need to approach final diagnosis at any cost for the patient. So let's characterize these lesions. First of all, we have to categorize the patients. A number of lesions have a difference in the sex distribution and the age, of course, at least between childhood and adulthood. And of course we will consider the history of the patient, cancer patient, chronic liver disease, or other things in the history, and we will try to check the previous studies. Today really a number of patients already have a number of studies, so it's better to look at the past than to perform other studies, other costs, and when it is not necessary. And so we will consider if the lesion was already present and if it was smaller or the size is the same, the laboratory and tumor markers, of course. And we must consider if the lesion grows in a normal background or in a fatty liver background. Then we have to characterize the lesion. So we must know which focal livers are common and they are more probable, and we will consider an uncommon diagnosis or a rare diagnosis only after having ruled out any common diagnosis. We must consider the structure of the lesion, being cystic or solid or intermediate, the number of the lesion, single, multiple, less or more than 4, the size of the lesion, the pattern of growth of the lesion, the position of the lesion within the liver parenchyma, and we must also check a number of other morphological features. We also have to keep in mind that there is a number of pseudo-lesions and mimickers of focal liver lesions that we must know and rule out. So, which are the three classical scenarios to consider the differential diagnosis of focal liver lesion? First of all, the really now very frequent incidental finding of a focal liver lesion in a patient with no particular clinical history, the problem of the cancer patient, and the problem of the patient with chronic liver disease. In the first case, we must consider that there is a really high prevalence of benign lesions, so the probability of malignancy is rather rare. Even in the cancer patient, it's not the more probable occurrence. We must know that the larger is the lesion, the more is probable its malignant nature. And since most of the subcentimetral lesions are usually benign, even in the cancer patient, multiple lesions suggest malignancy, particularly if more than 4. And a solid lesion is more probably malignant than a cystic one. So, which are the features of CEUS we must consider? The hemangioma shows globular or ring enhancement at periphery with a progressive fill-in, so a globular enhancement with subsequent centripetal fill-in is really diagnostic. FNH shows usually a centrifugal enhancement with a central artery with a very fast and strong enhancement, turning rapidly into a high superfusion of the lesion and with a central scar internally. Then the adenoma will show a more variable appearance, but this is too an hypervascularized lesion in the arterial face, being homogeneous or homogeneous mostly depending on the size, and the appearance in the portal and late phase is more variable. There is a number of findings helping us to differentiate from FNH, but I have to say that for very small lesions, this can be a difficult differential diagnosis. And pseudo lesions such as focal fatty liver or focal spared areas in the fat liver are easily ruled out with CEUS. And also the complex cystic liver lesion must be considered, because even a cystic lesion can be sometimes malignant if complex. And at the same time, a lesion apparently solid at baseline US can then turn out to be cystic after a contrast injection. So a very complex cyst, no enhancement at CEUS, and just an hemorrhagic cyst at CT, and this case was proven by aspiration of the lesion. So the scenario of chronic liver disease, and we must always consider that most of the new lesions found in these patients are HCC, particularly depending on the size. We must also consider that dysplastic nodules in the end turn to have a tendency to turn into overt ACC. The phytoprotein has a little role in very small lesions. In the case of multiple lesions, we must consider HCC, but also premalignant nodules or even sometimes lymphoma. We must consider the possibility of cholangiocellular carcinoma in the patient with chronic liver disease. Instead, we must also consider that metastases are rare in this setting. And the baseline ultrasound appearance is not enough to have a final diagnosis, because also hemangioma-like lesions can turn out to be hepatocellular carcinomas if we use other imaging modalities. As you know, along the way to overt hepatocellular carcinoma, there is an increase in the arterial supply and the loss of the portal venous feeding of the lesion, and this is reflected, of course, in the perfusional model of HCC, which usually show a strong diffuse enhancement in the arterial phase, as you can see in this image, and with a rather slow and not so strong washout. We must always consider that small or well-differentiated HCCs may do not wash out at all, and this is a limitation for characterization in comparison with the other imaging modalities. But also hypovascular HCC do exist, and this is a problem for differential diagnosis, but also for the other imaging modalities, as well as premalignant lesions, which can be somehow characterized. If we do not see any enhancement in the arterial phase, we usually describe this kind of lesion as dysplastic nodule, and in our practice we we do a short-term follow-up with CEUS at 3 months in this kind of lesion. Mostly depending on the size of the lesion, of course. This is another example of focal liver lesion in chronic liver disease. The most recent algorithms do not consider any more CEUS in the assessment of the lesion potential being HCC. You can find here only CT and MRI. Once there was, in the previous versions of these guidelines, the Europeans and also the American CEUS was included. Now they say that since a number of HCC do not wash out, we can't use CEUS. Also because some kind of overlap with cholangiocellular carcinoma, but this was based only on a single study on a few number of cases, so most of us do not agree with this statement. but it's the same statement of the American version of these guidelines, where only CT and MRI are considered because CEUS may incorrectly diagnose an HCC, which in the end is a cholangiocellular carcinoma. The third clinical scenario is the focal liver lesion in the cancer patient. You know that liver mets are really common. The tumors with a high frequency of liver metastasization and a high relative frequency of liver metastasization. Classically, some tumors develop hypervascularized metastasis, other hypovascularized. Most mets are multiple and located in the right liver lobe and at the periphery of the liver parenchyma, and up to 10% of the small lesion below the 10 millimeters found in the cancer patient are metastases. This means that 90% do not. The most frequent differential diagnosis in clinical practice is hemangioma, but also pseudo-lesion in the fatty liver background, since a number of these patients are undergoing or have a history of chemotherapy. The CEUS appearance of metastasis is some degree of enhancement in the arterial phase, annular, diffuse, homogeneous or heterogeneous, with no centripetal fill-in, of course, and a very fast and strong washout. So we will check for black spots with microcirculation inside, with moving echoes in real-time assessment during the portal and sinusoidal phase. In CEUS, really a majority of the metastases do show some degree of enhancement in the arterial phase. This is not seen with CT and MRI, probably because this is a very fast finding, so they enhance very rapidly and they wash out very rapidly, so only the real-time capability of CEUS allow to detect this finding. So, in conclusion, I will first show you the guidelines, the most recent update of the European guidelines, where CEUS is recommended in the case of incidental findings on conventional ultrasound, in the case of a lesion, of a possible lesion in a patient with chronic liver disease, or in a patient with staging or follow-up for extrahepatic cancer. And also, as I showed you, there is a growing role in the case of not conclusive findings at MRI, CT or PET. The problem of non-specific uptake of FDG at PET is very, very common in our practice. So, some conclusion. I believe that at least in countries where ultrasound is regarded as the first imaging modality to study the liver and the abdomen, and in countries where microbubbles are available, of course, CEUS has grown into a major tool to assess the focal liver lesion. Mostly those detected at ultrasound, but not limiting to these. So I fully agree with the title of this recent paper. And of course we must consider that CEUS, as CT, only rely on the knowledge of the vascular model of the lesion and on the perfusion behavior. MRI is a more sophisticated imaging modality, and it is based on a number of aspects, of different aspects of the lesion to be considered. And consequently, worldwide, there is a growing shift between from CT to MRI, but CT is still the most, at least in Italy, the most diffuse and standardized and confident imaging modality to study the liver. as I tried to show you, if we merge the type of patient, the type of parenchymal background, and the type of lesion in the various clinical scenarios, in most cases we can achieve with CEUS or other imaging modalities a final diagnosis in a non-invasive way. Even today, I believe that in a number of selected cases there is still place for biopsy, but it is the topic of other presentation. Thank you very much.
Thank you, Dr. Catalano. It's a very interesting and complicated presentation, and underline the important role of these new techniques and imaging techniques and the diagnosis, but also you have underlined the limits of the techniques. I think that the discussion will be at the end, or
no? If I think since we are going to speak about other issues that.
The end. Okay.
Any question about this presentation? Yes. Okay.
In those first algorithms you showed, when you came to a lesion that you thought was indeterminate, you had the arrow going to biopsy.
Sorry, which algorithm?
Well, ones that you showed right at the beginning about workup of lesions. Well, the question that I'm asking is, if after contrast enhanced ultrasound you're pretty confident that the lesion is malignant on the characterizations of the lesion, are your clinicians in the institution where you work happy to accept that without a biopsy, or do they still want histological confirmation of it?
I see the problem for the oncologist, but first, this does not apply only to CEUS. In many cases, to submit the patient to chemotherapy, the oncologist wants a final histological diagnosis, but this is not only in the case the diagnosis has been done with CEUS, also if other imaging modalities have been employed. So there is a legal problem to be considered. Otherwise, the oncologist feels the risk of a malpractice issue. If we talk about CEUS, I have to say that most of the oncologists in my institution have learned the correct use of this imaging modality, and they are we have their trust, and in most cases they will rely on our diagnosis. I have to say that there is frequently the opposite case. The oncologists come to me with a CT or MRI stating possible metastasis, probable metastasis. It tells me, if I call for a CEUS, will you write that this is a metastasis? So, and this is also in for the hematologists, for example, in the topic of lymphoma. In most cases, they call for a CEUS because you can do it quickly, you can do it in a very simple way. So they prefer to do immediately CEUS and not to wait for some days for scheduling a CT or an MRI study, from a very practical point of view.
Oh, I think the Orlando pointed out the real role of the CEUS, that is NE. You told it many times that it's mainly a solving problem tool that can be because it's not invasive but well tolerated. There are no really contraindication in repeating this examination more time. It's really a precious tool that can, if you have a relationship with other specialist oncologists radiologists, surgeons, you can understand when to use it to solve the problem. And it should almost never be considered an imaging that can give you the right diagnosis, but it is very precious in integrating the other imaging. Any other question?
How is important the role of operator in make a diagnosis? So how many practice you need to be a good guy?
I don't know, the idea of Luciano, it's of course you need a training as everything, and so you must be enough skilled with the baseline ultrasound first of all, and then with CEUS. The problem is that if you inject the contrast, if you do a contrast enhanced ultrasound, then you will have to do a diagnosis. Most sonographers prefer to perform their baseline ultrasound and then call for a CT or an MRI, so someone else will do the final diagnosis. Probably, of course you need training, but you must also want to achieve a final diagnosis with ultrasound.
Okay. Can I add something? You drew me on a bad way against the radiologist. That's right. Actually, it depends. To perform a good CEUS, you must be a good clinician, and this radiologist is a very good clinician. That's why you must be a good sonographer, and you must be able to assume your own responsibilities in the diagnosis. Not always say, okay, make this CT error, because CEUS can give you the final diagnosis. But to me, the main role of CEUS is integrating, and is really useful in performing interventional and even surgery. So we use CEUS in operation, in open operation too. That is really, really useful in this setting, clinical setting. So, but if for answering your question is, it's very, if sonography is more operator dependent than CT and MRI, CEUS is even more. So it depends on the operator. And an operator like Orlando Catalano in your hospital is really precious, and we hope to form, to train other physicians in performing this kind of important examination.
Okay, thank you. So, thank you, Dr. Catalano. We will move to the second presentation, Dr. Localli, that